Alright, because it wouldn't actually fit into the syringe, would it? Is that okay? So for this, everyone knows this, we've done this before, haven't you? So 2 ml syringe. A safe, what they call it, clips needle. So these are ones with the pink covers. We've seen these, I brought these over when Jim was over, didn't we? Alright, so that's what was it, 27 gauge, 1.5. Alright, so it's 27, so it's nice and fine. Because when we're injecting, the smaller the gauge of the needle, it's actually it's more comfortable for the patient and less painful. Right, when we're drawing the anaesthetic out of the ampule, we use a 23 gauge needle, which is a thicker needle. So the gauge, do you understand what I mean by gauge? The thickness of the needle, the thickness of the lumen inside the needle is actually what the gauge is. So it's a wider lumen, so it's easier to draw the drug up, okay? We need to get forceps because we need to take one needle off after we've finished using it, yeah? So I've opened my forceps already and they're ready to go. I need an ampule snapper, I need drug, and I need alcohol wipes. Alright, so I'll get everything I need before I start. So first thing we'll look at is the ampule snapper. Everyone happy you've seen one of these before and you've played with them? You see there's an ampule shape in it? So we'll open it out. First thing we do is give it a wipe. This is a reusable medical device, so you don't chuck it in the bin once you've used it. So if we're reusing it, you always give everything a wipe. So the same way you would your chair, your operator's lamp, anything like that, you're going to give it a wipe. So wipe. So I've already wiped down my tray and I'm good to go, so I'm going to pop that down now. Next thing I'm going to do is I'm going to look at my anaesthetic. So they come in packs like this, there's 5, I've removed 1. Right, so the day I ask you, you'll have these in front of you. There might be other drugs there as well, because there might be, because we work in a hospital, don't we? So there might be adrenaline. It looks different, it's different colours. So get used to how the ampules look, they won't change between now and exam time. Alright? So I give it a flick, making sure that it's got liquid in it. So I'm making sure that the ampule's intact, making sure there's no floaties in it, there's no liquid, there's no cracks in the ampule. Alright, so I'm happy enough that this is all intact, that the liquid hasn't been contaminated. It should be a nice clear liquid and it should move freely, there shouldn't be any bits in it, so you can see that. Alright? I'm then looking what I'm checking for next. What do you think? Expiry date, good. What else? Batch number, great. What else?
No adrenaline.
No adrenaline, good. What else? Percentage, good. What else?
The name of the drug.
Good. What else?
These are only foreign mushrooms.
What?
These are only foreign mushrooms.
Yeah, we've done that already, but yeah, you're right. No, so we're checking it's lidocaine because that's what we want to use. We're checking the percentage because we need to work out how much we're going to put in the patient, don't we? We need to make sure that it doesn't have adrenaline in it because you can get lidocaine with adrenaline. Dentists love that. Why can't we have adrenaline? It's a vasoconstrictor, so why is that an issue with the end of a tone? As opposed to a midriff digit. You know what I mean? Yeah, I know what you mean, I'm only joking. So it's a distal end, isn't it? So we're going down to the periphery, so end of your nose, your top of your ears, fingers, toes. We don't want to be vasoconstricting, so there's a risk with the vasoconstriction action of the drug with what we put on as a tourniquet, that combined, the blood might not come back to the toe. Right, the story I always tell is when I started working in practice after I graduated, I worked in the Isle of Man and I used to have a hyperbaric chamber, and one of my jobs was to sit in a hyperbaric chamber with the wound patients. Dull, but I got paid. So I'd go down and because if they had a heart attack or something, but it never happened. But one of the patients, one of the junior interns at the hospital had used lidocaine with adrenaline on his hallux, removed the nail, and now his toe had gone black. So they were trying to use hyperbaric oxygen therapy to see whether his toe would come back. It didn't, it was worth a try. So I spent 6 weeks listening to him complaining. So it's ingrained in my head I'll never use adrenaline. But you know, you can get it, so you need to be aware of it. Alright? So now I've checked for everything. Now you'll see on the ampule there's a blue dot on it. Can anyone tell me what the blue dot signifies? Weakest part of the ampule. So it's the weak point, it's the break point, isn't it? So when we're snapping our ampule on this, we need to see the blue dot. So when you put it into your ampule snapper, you want to be able to see the blue dot. So I'm going to pop it in. It's an ampule shape even, it's really easy. So what I'm going to do is I'm going to close the lid first. Why do you think I close the lid first? What can happen, see how it shifts a little bit? The shape inside the snapper is a little bit bigger than the ampule itself. So if you close the bottom first, what can happen is this can slip down, and that's how you can cut your fingers. It's still possible to hurt yourself with these if you're not careful. So hold it in position, close the lid first. So once the lid's snapped, it's in the right position, the neck is in the right position to be snapped. Alright, now we're good to go. Okay, now I'm going to open it again now because that's out of sequence, but that's the most important part. Is that alright? So that's ready to go, and I've checked everything there. Next I need to check is expiry date. Everything's got an expiry date on it. So there's an expiry date and a batch number that should be recorded as well. Now that's not necessarily part of the exam, but you need to be checking that. You don't use an out-of-date stock. Right? If they're past the sell-by date, you chuck them in the bin. Alright, you need to notify somebody. So we open them by pulling them apart. So if they have 2 tabs, you use them. We don't tear them, we drop it onto the tray. So what we're going to do now is we're going to snap the ampule, okay? So we're going to do this in 2 things. So I've done everything already. I need to make sure the liquid is in the bottom of the ampule now, okay? So if I've laid this down, see how the liquid's now in the lid? If I snap this as is, see how the liquid's still there? It's hard to see from there. If I snap it now, about half a mil of liquid's going to run down my hand. That's okay, but you're going to end up with 1.5 mil in the syringe. You'll have to prep more syringes. So what you do is, there's several ways of doing it. If you're big toughy, take your thumb and finger and tap it, and it goes. You see it's gone? You probably can't see it, but it's gone. There is another way of doing it, but this way breaches health and safety, so I'm going to show you, but I don't really see you doing it. Is that a contradiction when I'm not showing it? I'm not going to show you. Well, I've got gloves on. Flick. Day after you graduate, come and find me and I'll show you how I practice in reality. I'm only joking. But I'm flicking it. Right, you need to flick it hard, so don't be panicking in the exam. So for the exam, you need to get some drug out of this into a syringe and into a tome. So if you don't get all 2 mil, you're not going to fail. You're going to fail because you only have 10 minutes if you spend 7 minutes going. You know, just so don't overdo it, but you should be able to get most of the drug out, okay? So now I'm going to hold it like this. I'm going to do the blue spot out, close the lid, and close it. Now if I put this down at 90 degrees on the worktop, I'm going to put all the liquid I've just flicked out of the lid out again on top. So what I'm going to do is, I'm going to finish off the job now. So, thumb and finger, and close it. Right, these squeeze shut, but Anthony found one that springs open, didn't you? But they should squeeze shut, so trust it. If it springs open, you can go, cheap shite, but they want some buys and start again, right? But it's holding, isn't it? So now I need to put a needle on this to pull it out. 27 gauge needle, it's got an expiry date on it, it's got a batch number on it, so I'm going to record that for later. So what you do if you want to, rather than chuck them out, see I'm putting them behind me, so I can check it all later.
23 you got? 27.
This is the 23. What did I say?
27.
That's because the sell-by date is 7/17, but I'm just saying it's a 23 gauge needle. It's the blue one, smart ass. Alright, there's a big difference. See the big pink one with the pink cover on it, that's one we inject in. The blue one is the thicker one. Now you can draw the liquid out of this one, so not the end of the world. You won't fail if you use this one. We'll try it later when we're practicing, try it, because you'll find it more difficult to extract the liquid, that's all it is. Right, so see how I'm holding it? I'm going to pop on nice and loosely, and I'm going to put the packaging around everything else. I'm now going to use my thumb, my 2 fingers. Listen. Hear it creak? That's on securely. If I use my 2 fingers and push using the lid with this type of needle, I'm actually closing the lid more. You'll find it almost impossible to get off. So if you're on the exam and you're tugging, you might need to dispose this and start again because you forced the lid on too much. So when I'm going to take the lid off now, I'm going to put my thumb and finger there to hold it on. See how easy it was? I'm not going to resheath, you never resheath, but just to show you a demo, if I do this, you hear it click a bit more? And the danger I have there is, it's what we call a double bounce. So you pull out, and then you have this action, and your finger's bleeding. You haven't infected anyone, you just cut yourself in an exam. And I'll be sat behind you going, 7 minutes gone. You know, and you're going to have bleeding fingers, so just bear in mind, alright? So we're good to go. This goes in the bin now. So we dispose this straight away, so there's no chance you can pick it up and resheath. So chuck it. And if you only have a sharp spin, that's fine. Right, we're good to go. See, I haven't put this down now. There's no reason for me to put this down. I'm safe and in control. Put this down, that's a danger to you, and if it's sticking up, it's a danger to people walking past. You don't do it, alright? Now you have a choice. You can do it sideways, down, whatever way you want. I tip it upside down. I do like to do my pub trick. Do you know, you get a pint and pull the bar mat from underneath it and it stays there? That's what we're doing now. So the surface tension is holding it. Because I can see one side of the ampule has drug in, the other doesn't. So the other's a lid. So the second biggest mistake people make when they're trying to draw the liquid out is they go into the lid and try and suck it out and nothing comes out and they start panicking. Alright, so I can see there's liquid in this one, so I'm going to break the seal there and I'm going to pull. The biggest mistake people make when they're drawing the drug out is they force the needle too far into the ampule and they're sucking out air and they get panicky because they can't understand why there's drug not coming out because they're in the right one. And the reason for that is that they've gone past. So even if you have it this way, if you put it in here and you don't go deep enough, you'll be sucking air out. Do you understand that? There's only a little bit in the ampule, and if you hold it the other way and you go in too far, it's the same amounts, alright? So now I've got quite a lot in there, I'm quite happy with that. So I'm using my forceps now to remove the needle. Right, tip here is, you can see where the syringe meets the needle in this, okay? Really simple. If I squeeze here and do my 3 clicks, I've just shown you 3 clicks, haven't I? What am I doing? You're actually holding the syringe onto the needle and vice versa. If you go at the very top where it's square, it pops off. So you see what I mean? Where the male meets the female, if you squeeze where they meet, you're actually holding what you're trying to remove off the syringe onto the syringe. So come very high. Don't do it on the needle, but just do it there and pull. So you hold the needle still and pop it out. Is that alright? Now, this can sit down now, because look, so that can sit just there. The shoulder, the actual part of the needle and the syringe is going to come to the needle is in contact. Straight into the sharp spin. You're doing 5, keep your forceps because you need them again, aren't you? Expiry date of our 27 gauge needle, thank you very much. It's a big pink thing. I'm not opening it fully, I'm going to fold the paper back. This is a lovely square shape to it, so thumb and finger has it what we call a double lumen, a Lurlock lumen, alright? So you'll be able to see when you open them. So there's 2 holes in there. So when you come to put it on, it doesn't fit. Okay, so you hold it securely and you rock and it clicks in. That won't come off now. Alright? So I move the paper, I'll keep that for later to record it. Move this back. So look, this just tips back. These lids can't be shoved on, so you can hold it by the lid if you want. So they're self-limiting. Okay, happy enough? So we'll see how much drug we've got in it now. So you can see I've got a load of air at the top and I've got an air bubble at the bottom. We're now going to go to the injection point. We haven't got a toe, we haven't got tube balls or anything. Tube balls. Sorry, tube foam even. Thank you, Sean. So you've seen them to do this already today. Right, so I'm good to go now. So I wipe my toe. So I haven't put the syringe down. You notice that? I don't need to start faffing about. I prep where I'm going to inject. So if I need to move myself, I don't walk around like this, okay? Because that's a danger, isn't it? Not very much you want, because I'm hardly going to stab myself, but it's just, there's no need for carrying drugs like that. So this can be popped down on the tray now, because this tray is clean. So if my patient sat in this chair, which they probably will be, if the toe's down here, I'll get myself comfortable with a chair. It isn't one like this, but it'll do. And I'll bring the tray to me. So it's safe, isn't it? So I swab down my toe, blah blah blah. What do we do with this? Dispose of it every time, alright? So I don't want to see it in your mouth. I don't want to see it in your hand when you're injecting. It all happened, alright, last year. This has to go, so don't put it back on the tray you've just used. It has to go straight to the sharp spin. But it's on the floor, but I'd rather that than in your hand. Okay, because as soon as it's in your hand, I'm thinking there's lack of understanding that that can't go back on, alright? So before I inject, I can just lash this into the toe, can't I? Good to go? What?
The air bubble in.
Warn the patient. Yeah, okay, so I've warned the patient. I'm going to stab you in the toe. Good to go?
No.
Air. Right. I've got a 0.5 ml of air there and a 0.25 in the bottom. Okay, so the first thing I do is I'm going to give it a tap. Again, we're tapping with the thumbs, alright? You can tap with your finger, I don't care. But I moved all the air up to the top. You don't have to get every single tiny little bubble. When you suck this liquid out, you'll see that it forms tiny bubbles in the plunger. You're not putting all this liquid into someone anyway, but just try and get everything out. We're in an exam now, okay? I'll be sat about 2 foot behind you. I need to see that you're actually getting all these bubbles out, that you're not going to put them in. So they're all gone. But now we're left with a load of air, so what do we do? Expel it from the setup, okay? So it's coming out of the syringe and through the needle. We're doing 2 things here. This isn't A&E. Can't if you fall asleep, I'll throw this and stab you. Right? This isn't A&E, so I don't want to see, stand clear! and then a big shoot over the bloody patient, alright? That's not what we're doing. We're getting rid of the air and we're checking that the needle works, because these are made in their billions every day. So every one now and again you get one that's blocked or doesn't have a lumen. Alright, so you can see the liquid running down it. But what I'm going to do is I'm going to force the liquid out, the air out first. But I'm using the liquid. So see how there's some liquid there? I don't care about that. That's gone. I've lost that. I'm forcing up now till the neck fills. And now what I do is I'm going to force some out. You see little beads of liquid coming out? That's my needle checked. Once the air's gone and the beads of liquid comes out, I'm good to go. I don't need to lose half the liquid to a test. Alright? So now I've tested like that, and I rotate, so the patient's behind me, everything's safe, I'm sat in a good position, the toe's ready. So where do I put my other hand? Underneath the foot. Feel for the needle when I'm going through. What do we do? Either side. So medial lateral. So this is where you've got a bit of a choice. I know Jim likes to teach you to stretch the skin with thumb and finger like this, does he? What I suggest you do is you take the distal phalanx and you actually hold it medial lateral. And if you want to get a bit of skin tension, all you do is plantar flex that joint, okay? So plantar flex the toe a little bit, and what you should get is skin stretch, yeah? You probably do without realising it. You might see some of our practitioners using thumb and finger at the apex and tipping. We're trying to not teach you that, because you're putting the finger underneath the toe, and that's always a little bit of a risk. But once you've been out there for 20 years, you'll find that you're that good with the needle, you can tip the toe, thumb and finger. But for now I want to see medial lateral, just past the joint and tip. And what that does is it stretches the skin. So if you do it with your thumb now, you just bend your thumb, all joking aside, can you see that you get a bit of skin tension? So you're well away from the injection site, tip it down, and you're good to go. Is that alright? So this isn't a dummy toe. Someone's stolen a dummy toe, I think, haven't they?
It's either someone's left it somewhere safe or someone's...
Somewhere safe, yeah. One of you has it. It's always someone who's got an exam coming up and it reappears. I wouldn't take it home. It looks
We were
a bit
using
bad.
it with Nigel yesterday.
Right.
Yeah.
Did it fall into your bag, did it?
Nice problem.
Did it accidentally get up in your mantel pieces?
I wish I had one.
You've got two! No, we'll find it, but look, we'll go here now. So we tip, okay? Doesn't matter which side. Where do we inject? Describe the injection site for me before I do it.
Just distal to the first MTPJ.
Just distal to the first MTPJ.
2/3 between the IPJ and the MTPJ.
Okay, anyone else? Proximal phalanx, anyone else?
Dorsolateral aspect between the first MTPJ and the first MTPJ.
Yeah, you all said the same thing different ways, and that's fine. But anyway, as long as I know what you mean. So you'd start with the dorsolateral aspect, would you? So start with dorsal. As long as it's dorsal, you're not sticking up through the bottom of the toe. As long as you're not on the joint capsule, and as long as you're not directing the needle up or back or sideways. This is a 90-degree injection, so you're coming 90 degrees to the skin, aren't you? Right, now what I'm going to do now, I'm going to rotate my setup a little bit, because I have a preference. I like to see the scale when I'm injecting. Alright, so I don't have a problem with you taking thumb and finger and rotating the setup. Look, I'm not doing any harm, I'm not introducing bubbles, but because I'm left-handed, I'm going to inject like this. So I like to see how much I'm putting in. That makes sense, doesn't it? So whatever your preference is, but you need to be able to tell me. If I tap you on the shoulder, you should be able to tell me how much drug you're putting in. Alright? So we're going to pop it in. So 90 degrees, so our injection site is distal of the MTPJ, but proximal of the IPJ. And it doesn't matter if it's medial or lateral, but you need to know if it's medial or lateral, if that makes sense. So I might say to you, where are you popping it in? Oh, this is the left foot, Mr. Watterson. I'm going to stick it in the medial side first.